Welcome everyone, Jim Thorpe, CES. This one's on breast cancer, upper extremity disorders. Real quick, I just want to let you guys remind you on September 22nd, which is this Saturday, we have our Jim Thorpe Courage for Recovery Conference. 8-hour CEU, that's speech, OT, PT, case management, nursing, quite a few that already have been pre-approved for our conference. If you want to come to that, you can go to our integrasok.com/JTED, and on the left it tells you who you need to email for a registration fee and price. If you're an Integris employee, you don't have to worry about it, but it tells you where to go if you are an Integris employee. And then we're just finishing up our fourth quarter CES flyer, and that will be out hopefully this week. First of next week. The first course we have on there is October 12th. It's our ethics course. And yes, I know, we scheduled this way in advance. That is fall break, and that is OU Texas. We are going to be done by 4, so you guys still make it to Texas if you want to go to OU Texas and have plans, but we already set this up with our speakers, so we didn't want to cancel it. So we're still going to do that. We have a morning course at 8:30 to noon, and then an afternoon course 1 to 4, 3 hours of ethics, so you guys know. And the one after that is actually Krista Nugent's class about lymphedema. So that's the one after that from 12 to 1. All right, so with that, we'll get started. I'm going to introduce Dr. Keoli. She is, right now, the staff physician at ICIO, the Integris Cancer Institute of Oklahoma and Baptist. She was an assistant professor at the University of Florida College of Medicine. She has other postdoctoral training like acupuncture. She's done many publications and some invited presentations, cancer rehab that she's done here. And I think that's all. So we want to welcome her, and thank you very much.
Dr. Keoli.
Okay. So basically, I'm going to talk on breast cancer and upper extremity disorders, specifically in breast cancer.
Can we make sure your mic is on?
Is it on?
Yeah, it should be in your packet. Yeah, sure.
Can you guys hear me? No? Well, it has a green light here. Okay. Now can you hear me? Yes? Okay. So the objectives here are basically to be familiar with the upper extremity morbidity seen in the breast cancer population, be familiar with the treatment modalities, and be able to identify situations where possibly your patients may need to go back to see their primary care provider to rule out any serious ailments. So basically, upper extremity morbidities are alterations in the use and function of the upper body. As many as 60% of women report at least one upper body symptom. By Hayes. This is limited in that the studies have varying lengths of follow-up. And upper body morbidities are common now, despite advances in treatment.
They're starting to go down over there. Yeah, let's give it a second. I'll get back up.
They're associated usually with older age, lower socioeconomic status, dominant side involvement, and more extensive surgery. And these are seen usually between 6 months and 18 months post-surgery. So before I go on any more about the morbidities, and I'm sorry this is not in your handout, but I wanted to talk a little bit about the treatments that we have for breast cancer. This is just in general. I'm not going to talk about, based on the stage of the disease. But I'm sure, when you all look at your the patients that you are sent or referred, you see that they've had a modified radical mastectomy or they've had axillary node dissection. So I just wanted to go over a little bit about exactly what these involve. So breast conservation surgery, or BCT, is basically just excision of the tumor and some surrounding normal tissue. Mastectomy radical mastectomy, which was the first one done by Halstead, is basically removal of the entire breast tissue and the pectoralis muscle, along with all the axillary lymph nodes of levels 1, 2, and 3, and I'll explain what those are. Total mastectomy is basically the radical mastectomy, except the pectoral muscle is left intact. So the pectoral muscle fascia is removed along with the breast tissue, but there is no removal of the pectoralis muscle. And the axillary node dissection is not done. Whereas a modified radical mastectomy is a total mastectomy along with axillary node dissection. And in axillary node dissection, generally, when they say complete dissection, about 15 to 20 nodes are removed. The 3 levels are divided based on the location of the node with respect to the pectoralis minor. So if it's lateral to the pectoralis minor, that's level 1. Deep to the pectoralis minor is level 2, and lateral is about level 3. Nobody knows exactly how many lymph nodes each and every one of us has because it's different. So that's why they say if 15 to 20 nodes are taken out, it's considered a complete dissection. So radiation therapy, this is not always indicated. And some of the incidences of complications from radiation therapy has decreased, including lymphedema, because now, for example, radiation to the axilla is not always given. Breast conservation therapy, only if radiation is indicated. Usually about 5,000 gray is given over 6 weeks, 25 treatments to the whole breast, and then 5 if indicated to the tumor bed. Post-mastectomy, again, radiation is not always indicated, but it may be given at the chest wall. And so that's important, if you're looking for radiation fibrosis or tightness of the incision, etc. Chemotherapy, as you can see, there are different regimens. Now, the one most commonly that I've seen the oncologists give at ICIO now is the TAC, which is taxotere, adriamycin, and cyclophosphamide. Importance in this is taxanes are associated with neuropathy, and I'll talk about that a little bit later. But in addition, if it's hormone sensitive, you might see drugs like tamoxifen, or if they're postmenopausal, aromatase inhibitors. And basically all these do is estrogen deprivation. Okay, so what upper body morbidities are we going to talk about today? Lymphedema, brachial plexopathy, neuropathy, arthralgias, or basically of the shoulder, wrist, and hand, because I'm talking about the upper body, shoulder dysfunction, cellulitis, deep vein thrombosis, axillary web syndrome, post-mastectomy syndrome, and pain. Now, obviously, pain can occur with almost all of these, but then there are some other causes of pain as well. So lymphedema, as we know, it is the result of functional overload of the lymphatic system, which is basically that the lymph volume exceeds the transport capacities. And at least 20 to 30% of breast cancer survivors will experience lymphedema, with the majority of cases is up to 80% occurring within the first year. So it is basically a disruption of the lymphatic system, which causes accumulation of fluid in the interstitial space and manifests as swelling, not only of the arm, but can also be of the breast, the torso, neck, or shoulder. And sometimes also isolated of the hand alone. And in later stages, this can result in fibrous tissue deposition or adipose tissue accumulation. Patients usually present with symptoms of limb swelling, heaviness, pain, pitting of the skin, tightness or hardness in the limb, and reduced mobility. I just want to share that there was a study done, and ironically, 40% of patients who had objective evidence of lymphedema did not complain of it. But then on the flip side, 40% who had no objective evidence of lymphedema complained of limb swelling and heaviness. So, there are different ways out there to measure it, but there's no gold standard. Even the water displacement, which is basically putting the arm in a big thing of water, and seeing how much volume is displaced is extremely inconvenient, and it's not portable, but that is thought of right now as one of the gold standards. and about 200 ml is thought to be is the cutoff for lymphedema. But bioimpedance spectroscopy is, even though it's only indicated for pitting edema, it may be more sensitive than water displacement barometry or circumferential measurement in detecting the accumulation of water in the extracellular tissue. Barometry is used more in research studies only because it is actually very accurate. It uses infrared light, and it is much easier and more reproducible. But circumferential measurements are usually what are used in most clinics. So the risk factors are, so ALND is axillary lymph node dissection, which, and you see much lesser with sentinel lymph node biopsy. So sentinel lymph node biopsy is where they put a dye to see which lymph nodes, if any, are involved. And this obviously decreases the number of patients who are subjected to lymph node dissection. Anthracycline-based chemotherapy regimens are also found to predispose to lymphedema. And we don't know why the chemotherapy agents cause it, but it's hypothesized that maybe patients who are candidates for these anthracycline-based regimens may just have a higher tumor load. So they may be predisposed to lymphedema, whether they get the anthracycline or not. Higher body mass index and axillary radiation. Of course, we always tell the patients, reduce your risks in terms of try to avoid getting infection or try to avoid wearing tight clothes, but they really, and this seems very logical, but there is really no studies done to prove that any of these increase the risk of lymphedema. Because this is, if you use the same train of thought, you'd think that exercise, which increases blood flow to the arm, would increase your risk of lymphedema, but studies have not found that it does, or weightlifting or anything of that kind. So treatment, we still will continue with patient education to reduce the risk, which is basically decrease anything that might cause scarring of the lymphatics, such as infection, try and avoid getting any needle sticks in that arm, try and avoid compression, so basically obstruction to lymph outflow, which is by avoiding wearing tight clothing, tight jewelry, or blood pressure cuffs, or hot saunas or hot baths. Physical therapy, very important, involves manual lymphatic drainage and compression bandaging, massage of the scar tissue, and progressive exercises. Also compression garments, pneumatic pumps, low-level laser, and I will say it's not FDA approved here, but it is used in Europe. And there are some promising studies, but of course not the highest level of evidence. Medications such as benzopyrones, shown to have higher risk of hepatic impairment, but then antidiuretics are used very often, especially Lasix. Surgery, mainly reserved for refractory lymphedema, but it can involve debulking and removal of excess tissue or lymphovenous anastomosis. Moving on to brachial plexopathy. Now, thankfully, this is very rare, even in women for whom supraclavicular and axillary regions are treated. That's because of the advent of more sophisticated ways of giving radiation. The frequency of neoplastic brachial plexopathy is only 0.43%. So this is basically because of tumor. And this is supposed to involve more of the lower trunk and is supposed to be more painful than radiation plexopathy. Radiation plexopathy in treated patients is 1.8 to 4.9%, and this is supposedly thought to involve the upper trunk more, though that is controversial, and pain occurs after sensory and motor impairment. So pain is supposed to be less in patients with radiation plexopathy. The one ironic thing is if it's tumor-related, then the treatment for brachial plexopathy secondary to tumor is radiation. But then survival of patients with tumor-related brachial plexopathy is very low. The causes, as I mentioned, the side effects of radiation or metastasis in breast cancer. And the symptoms are pain, usually very severe if it's related to the tumor, and muscle weakness and paresthesias. Treatment is usually physical and occupational therapy. This may not reverse the plexopathy, but it will help with managing some of the symptoms. Pain medications. Sometimes opiates are needed, but usually it's neuropathic pain medications like gabapentin, Lyrica, etc., Cymbalta. And these patients may require a sling or an arm support. Neuropathy causes chemotherapy, especially taxane-based chemotherapy regimens. This is mainly a sensory neuropathy. It does not affect the motor component as much, and it is cumulative. So the longer they get this chemotherapy, the worse their symptoms are going to be. So in the upper extremity, we need to work on fine motor skills and coordination. Surgery, usually the intercostobrachial nerve, if that's been lesioned, then they might have some paresthesias and numbness in the axilla or the posterior arm. Obviously, if the thoracodorsal nerve is lesioned, then they'll have weakness of the latissimus, or if the long thoracic nerve. So obviously, you won't know that these have been lesioned unless you look at the operative report, and if it's mentioned in there. But if you see winging of the scapula, then you know that they've had some lesion to that nerve inadvertently. Obviously, the patient has diabetes or drinks a lot of alcohol, or has thyroid problems, and they're more predisposed to getting neuropathy from chemotherapy, especially. Treatment is generally medications, again, neuropathic pain medications like gabapentin and Lyrica. Occasionally, they might need some steroids, or they might need some opiates, which we try to avoid. And physical therapy to work on basically deficits in fine motor coordination, or they might need, if they have weakening of the winging of the scapula, they might need strengthening of those muscles around the shoulder girdle, and they might need orthotics. So arthralgias are joint pain. This has been found to be associated with the use of aromatase inhibitors, which is Arimidex or Aromacin, and these are usually used in postmenopausal patients with hormone-sensitive breast cancer. Wrist and hand has been found to be the most common occurrence of these arthralgias in the upper extremity. That's about 60%. In the lower extremity, obviously the hip and the knee were the most common cause. We don't really know why, but it's hypothesized that maybe because of estrogen deprivation, because that's all that these aromatase inhibitors really do. But they also think that it's possible that they cause autoimmunity and they cause the development of antibodies to the cartilage. So because it's also been found that they have a higher tendency to effusions. They may be painless, but just joint effusions with no other symptoms of no other objective signs of arthritis. So we treat them just the same as you would with anybody else that has arthritis, because you cannot. In 20% of patients, they do stop the aromatase inhibitors because of these arthralgias, but usually the benefits outweigh the risks, so we have to do supportive management with pain medications. Sometimes you can check vitamin D levels, and if they're less than 66 levels, then we advocate vitamin D supplements. Over-the-counter supplements like glucosamine, chondroitin, they never hurt. Acupuncture can be tried because it has less systemic side effects. Physical therapy to work on strengthening of the muscles, and weight reduction if indicated. In the upper extremities, not as much, doesn't make as much difference. Shoulder dysfunction. Of course, shoulder dysfunction occurs because of pain. I have said adhesive capsulitis, but adhesive capsulitis can occur because they just don't move their arm because they're having pain, either post-surgery or, or it could be because of some tendinitis. Development of scar tissue. They could just be having some shoulder pain. Some of it may be pre-existing, just worsened, or it may be because of the way that the arm was placed during surgery. Thrombosis and thrombophlebitis of the superficial veins of the arm. This occurs especially if they've had IVs. The IVs have been there for a prolonged period of time. We also have to remember that a lot of these patients, if they've got neoadjuvant or that's chemotherapy before they had surgery, then a lot of them do have a port placement. Usually that is on the contralateral side, but if for some reason they have it on that side, then they're predisposed to developing thrombosis. And they might also have pain from the port. So basically, we need to identify the primary cause as to why they're having shoulder dysfunction. But I just want you all to be aware that shoulder dysfunction is one of the most common morbidities seen in patients with breast cancer. And medications, again, pain medications usually are anti-inflammatories. They might need injections in the shoulder joint or the subacromial bursa just to help with moving the arm. In conjunction with physical therapy, I always tell my patients, if I'm going to inject your arm, you have to go to physical therapy because, that's the best, you're going to get the best use of the injection. Because even if I inject you and you have pain relief, but you don't move your arm on your own, you're going to be back to square one. And then, of course, patient education on a home exercise program. Because, for example, if they have adhesive capsulitis, as we all know, it takes a long time for them to get better. So just to motivate the patient and tell them that they need to continue all this beyond just the physical therapy. Cellulitis. This is seen of all the kind of cancers, all the tumors, most commonly seen in breast cancer. And this is about 24% incidence. Cellulitis, another name or another kind is erysipelas. The big difference between these two is that cellulitis involves the whole length of the dermis and subcutaneous tissues, while erysipelas is mainly just the upper dermis. And they might appear the same to the naked eye, and the treatment is usually the same. The erysipelas are by a different organism and can present with, the patients will usually present with fever and more systemic signs than cellulitis, which can have a more indolent course. Differential diagnosis is radiation recall. So they look the same. The skin looks absolutely bright red, but it's usually in the region of the radiation. And this is if radiation is given very soon after the conclusion of certain chemotherapy agents. Cutaneous metastases. So that's why when you see a patient, with red skin, of course, infection is on the top of the list, but if, in addition to starting antibiotics, sometimes you just need to have the oncologist look at it to make sure that it's not metastasis. And then sclerosing post-radiation paniculitis, which is infection after radiation. And paniculitis, basically, it involves the whole skin thickness. So here, erysipelas is supposed, though I cannot really tell, but they're supposed to be more well demarcated at the edges than cellulitis. And the reason for that is because cellulitis extends deeper than erysipelas. Treatment, if it's extremely painful, we give analgesics, and then, of course, antibiotics, usually the drug of choice, unless they have any infection, is penicillin-based antibiotics. The one thing is, in cellulitis, we always have to make sure their blood pressure is well maintained, that they don't have any other systemic signs of sepsis. Because, as you know, most cancer patients, especially if they're undergoing chemotherapy, are very immunocompromised. So even a minor infection for them can progress very rapidly. Deep vein thrombosis. This is commonly seen in cancer, and that's because cancer cells secrete some procoagulants. But in addition, tamoxifen, probably again from estrogen deprivation, increases the risk of DVT. But, I just said estrogen deprivation, but AIs or aromatase inhibitors have a lower risk than tamoxifen, and we don't know exactly why. But in a study, tamoxifen patients had about 1.7% chance of getting a DVT, while those on aromatase inhibitors had just a 1% incidence. Chemotherapy, because the drugs damage the vascular endothelium, they predispose these patients to develop thrombosis. So obviously, if you have any patient who's in therapy, while they're undergoing chemo, and you see a swelling of the arm, Yes, you will think of lymphedema, but you will also, especially with sudden, think that this may be DVT. Obviously, the more dangerous one in this is DVT. The highest risk of thrombosis is in postmenopausal women. And interestingly, erythropoietin-stimulating agents, which are usually given during chemo, to help them with their blood counts, have been associated with higher rates of thrombosis as well. And when I say thrombosis, in this case, it's not just DVT, but it's also stroke. So basically, symptoms: these patients present with pain, swelling, and they may have erythema and warmth of the extremity, but that's not always a given. But usually it will be painful and swollen. Usually it's very acute. There's certain cases where it's insidious, but usually they'll just come with a very big extremity. I would like to say that DVT sometimes occurs just proximally, so you may not have swelling of the whole arm, but that can occur especially in patients who have PICC lines or ports, and that is when they have subclavian or axillary thrombosis. So management is usually bed rest until they're stably anticoagulated. Obviously, if they're not on Coumadin, then it's not with INR, but if they get a few doses of Lovenox, then they're usually good to move their extremity. In the upper extremity, we cannot put filters to prevent the clots, so there's a higher risk of PE, which always needs to be thought about, especially if they get breathless. The patient needs to be sent back to the oncologist to see if there's any other secondary risk factors for why they may have developed this clot, and then risk reduction. Basically, just if there is any other cause, then just tell them, and if they're on Coumadin, they need to change their diet. Okay. Axillary web syndrome. Basically characterized by axillary pain, or rather pain that runs down the medial arm. So it starts in the axilla, then goes down the medial arm. It causes limited range of motion, mainly in shoulder abduction and flexion. And then you can feel palpable cords. They seem like guitar strings of subcutaneous tissue which extends from the axilla into the medial arm, and sometimes also all the way down to the thumb. Though the patient might be, very worried about this, it is self-limiting. And this is not seen immediately after surgery, but usually seen sometime about a week or a month after surgery. It is self-limiting, as I said, and usually within 3 months it resolves itself. But physical therapy can shorten the duration, per one study, almost by 6 to 8 weeks, which is significant, especially if it's in the axillary region and limiting range of motion. And physical therapy usually involves gentle massage and myofascial release techniques and gentle range of motion of the shoulder. The cause of axillary web syndrome is supposed to be, or rather on pathology, when this tissue has been examined, it's basically scarred lymphatics that has been found. So post-mastectomy syndrome, basically these patients, they're usually post-surgical. They have burning, stabbing, tightness, and aching in the axilla, medial upper arm, chest, or in this region of the incision. So the causes are phantom breast pain, and so that's basically because it's almost like they've had an amputation. They've had an amputation of their breast, so they get sensations, and these can take up to a year to resolve, usually, so the patient just needs to be reassured. It can be incisional pain, and intercostal-brachial neuralgia, and these are nerves that are mainly in the axilla. Their root is the second thoracic nerve. And then you can have neuroma pain, if the nerve is caught in the incision. So physical therapy, if it's neuralgia, then basically just skin desensitization by gentle massage. If it is incisional pain, again, just try and mobilize the incision as gently as possible. If it's adherent to the underlying skin, work on range of motion to prevent shoulder dysfunction that might occur as a sequelae. And then generally, as physicians, we just give pain medications. So our last topic of upper extremity pain. So in addition to all that we've just talked about today, we can also have, in breast cancer patients, you always need to think of tumor or cancer. that might have occurred, or there might be metastasis to the bone, or there might be some fractures. In addition, they can have tendinitis not just in the shoulder, bicipital tendinitis, but they can have lateral and medial epicondylitis. De Quervain's, this has been found to be very common. And then we talked about arthritis, cellulitis, and DVT. So that's all I have for you today. Do you guys have any questions? Okay. Well, I hope you all understood everything that I was saying. But thank you very much.